Good afternoon, everyone. Welcome to the Food as Medicine panel. You're in the right place. I know there's a maternity panel going on right now, and I might confuse you, but this is the right room, all right? I'm LaTasha Seliby Perkins. I'm a family physician at Georgetown, and I have the honor of moderating today's Food as Medicine panel. We have some fantastic professionals on the stage. We're gonna ask a few questions of them, and then once I ask my questions, this is going to be an interactive panel. So please have your questions ready. We understand that we are the last panel standing between you and lunch, so we'll be mindful of that. But please be prepared to ask questions. Does that sound okay? Okay. I'll say I'm gonna do that again. So I'm African American from the Black church. So response is important to me. Everybody else, is that okay? Okay, that sounds better. All right, so the first thing I'm going to do is introduce you to our panel. And just so we're all on the same page, I'm going to read the educator in me wants to read the definition of food as medicine for you. Don't take this the wrong way if you're like, I do this for a living. I didn't know, not trying to offend anyone. Just want to make sure we're on the same page. Food as medicine is the concept that what we eat can play a key role in preventing, managing, even treating disease. It emphasizes the idea that healthy, nutrient-rich diet is one of the most powerful tools for maintaining wellness and addressing chronic conditions like diabetes, heart disease, obesity, and more. So let's go ahead and introduce our panel. I'll start with, on my right, Mr. Eric Mitchell. Eric is the president of Alliance to End Hunger, where he leads the organization's strategy to expand and mobilize a diverse network to build the public and political will to end hunger in the US and globally. Previous to this position, he worked for Food for the World, advocating for critical food assistance programs for our world. That's Mr. Eric Mitchell. Next, we have Ms. Kelly Horton, the Senior Vice President of Public Policy and Government Relations at the Academy of Nutrition and Dietetics, the world's largest organization for food and nutrition professionals. Kelly oversees the Academy's public policy agenda and advocacy efforts that promote health and reduce the burden of chronic disease through evidence-based nutrition services and interventions. Kelly is a registered dietitian, and her experience includes launching a novel nutrition intervention which grew into a basis for what is now known as the Food as Medicine movement. So just a pen if you want to ask her about that later. It'd be a good thing to ask Kelly about. Next is Dr. Kofi D. Essel, MD. He's a board-certified community pediatrician at the Children's National Hospital and clinical associate professor of pediatrics at George Washington University School of Medicine and Health Sciences in DC, most recently serving as the director of the GWU's culinary medicine program. He is currently the inaugural Food as Medicine program director at Elevance Health, and he'll tell you more about that later, or you can ask him specifically about that. Give you all some little nuggets to ask questions about. And last but not least is William Billy Dwyer, serves as our senior legislative assistant for Congresswoman Robin Kelly. Billy covers a diverse legislative portfolio and leads the Congresswoman's Food as Medicine efforts, including the introduction of the Food for Health Act in the 118th Congress. So that's Billy. All right. I have a few questions prepared for them. We'll start there, but again, please be prepared to ask any questions that you want, as we will have a question and answer segment that will come early in our program, okay? So starting with Eric, you ready? Mm-hmm. All right, first question. What important role do the federal nutrition programs such as SNAP and WIC play in the food as medicine space?
Well, thank you for the question, and I'll start off by just giving a quick overview of who we are as the Alliance to End Hunger. We are a coalition of over 100 national organizations spanning across multiple sectors. So we have businesses, corporations, faith-based groups, universities, foundations, even individuals, international NGOs, U.S. NGOs like Share Our Strength, Meals on Wheels, Feed America, et cetera. And our goal is to move policies forward that will put us in the path to ending hunger and malnutrition, not only in the U.S. and globally. To answer your question directly, the role that our federal nutrition programs play, across the board, we believe that a foundation of providing healthy foods, making it available for everyone has to be key. And our nutrition programs play a central role to ensure that everyone has the access, can afford, and that healthier foods are available to people across the board. And so when you look at our programs, our nutrition programs like SNAP, WIC, school meals, even some of our senior nutrition services and other things, these programs range across millions of people. SNAP alone has covers over 41 million people in this country. Within that program, there are certain incentives within that program that helps to make healthier foods more available. SNAP Ed is a way for local NGOs work with local state governments to do education training around healthier food options. There's things such as the GusNIP program, which makes healthier fruits and vegetables more affordable and for low-income families. There are even incentive programs like Double Your SNAP Bucks, where for every a SNAP dollar you use in buying healthier food options, it gives you twice the amount in return in regards to the healthier fruits and vegetables you can afford. Studies have even shown that individuals who use these incentive programs consume more fruits and vegetables than average Americans who don't. And so to answer your question directly around the role that federal nutrition programs play, they help to expand access to healthier foods. They also make healthier foods more affordable, and they make them more available for the most vulnerable communities.
And that's extremely important, because if you look into, as we all know here, the communities, there are food deserts. There are, grocery stores that may not have the produce that our patients, our communities that we serve need. And so it's extremely important that programs exist that definitely support us eating better, because food can be medicine. So I want to move on to Kelly. In your role as a registered dietitian, I want to know more about what that role plays in this Food as Medicine initiative.
Sure, thank you. So registered dietitians, or you'll hear us called RDNs, registered dietitian nutritionist, we play a critical role in screening, assessing, and then tailoring nutrition interventions for people and ensuring that food as medicine interventions are clinically appropriate, culturally responsive, and aligned to the patient's medical needs and treatment plan, not one size fits all. And RDNs put into practice the concept of good nutrition to promote health and to prevent or treat disease. If you hear the term nutritionist versus dietitian is trained in what's called medical nutrition therapy. So we are looking at evidence-based science to treat a patient. And we use those evidence-based science and interventions to treat chronic disease. It's really the cornerstone of what we do and has been proven to help with diabetes, dyslipidemia, hypertension, HIV, eating disorders, renal disease, and a whole bunch of other things. And you mentioned my involvement in the beginning, so I just want to mention that it's really exciting to see food as medicine become a movement. About 20 years ago, a small group of dietitians came together. I was not part of the group that thought of the idea, but I helped to activate the idea. Came together and said, what if we, and they were working in community-based organizations that were serving folks with HIV and AIDS and expanding to serve folks with diabetes and chronic disease, and often those patients actually overlapped. And they said, what if we could offer medically tailored meals, nutrition counseling, medical nutrition therapy, produce prescriptions, medically tailored groceries, and have a proof of concept that proved to reduce chronic illness and also healthcare costs, and we could then have a proof of concept that we could get Medicaid to pay for it. So we're 20 years into that policy intervention, which is sort of like the life cycle, so to see real change happen, so it's very exciting to see that happen. But we still have a long way to go to make sure everybody has access. And then maybe the last thing I'll just add is that the counseling by the registered dietitian is vital, but it's often not paid for. So right now, dietitians can get reimbursed for care that they provide for diabetes, renal disease, and post-renal transplant. Like I mentioned, there's a whole host of other diseases, such as obesity, diabetes, heart disease, cancer, that are not currently reimbursed. So people can go see a dietitian, but they may not get the full complement of care that they could get if we got full reimbursement. So that's something that we're working on, and I think there's a lot of momentum to get that moved forward with the medically tailored meals as well.
Amen. Sounds like a few action items that we're already getting early on. How many people just learned the difference between a dietitian and a nutritionist? Be honest. You can put your elbow up or maybe just say it to your neighbor, but that's an important point. And so we're hoping that we're learning and we're sharing this, but thank you so much for letting us know exactly the difference between the two so you know how to use the right terminology. I do want to move to Dr. Essel to ask a question of more in the lines of what you do as an educator. Can you describe the gap in nutrition education and medical training, and how does this impact the food as medicine movement?
Yep, excellent question. So recently I transitioned to the payer world. I work at Elevance Health, and I'll be able to talk about that more with questions moving forward. But before that, and actually currently right now, I still do a lot of teaching, but I was actively invested in sort of educating the next generation of providers and how they can incorporate more nutrition into how they care and work with patients and families. And some of you may say, well, why do you need to do that? Doctors know a ton about food and nutrition. That's part of the curriculum. If you really look at sort of the timeline, you can see some big gaps. 1985, groundbreaking report from the National Academies. National Academies brought together a group of leaders from around the country and said, hey, let's look at what's going on in medical training. How are we training the next generation of providers to sort of address the current challenges around food and nutrition? Malnutrition, diet-related chronic conditions. How are we doing this? So they looked at the data around the country. They asked a lot of different medical schools, and they found that the vast majority of medical schools weren't really incorporating this. When you looked at the data, what we saw was at a minimum, they said, hey, we're not doing a good enough job at incorporating this. They said, at a minimum, we need 25 hours of nutrition education in medical school. This is at a minimum. And so this was in 1985 that this was recommended. Years later, things have gotten so much better, people would say. The most recent literature shows us that when you look across the country at all medical schools, you're seeing about 71% of them fail to meet the minimum number of 25 hours of nutrition education. Okay? A third of these schools don't even meet half of those hours. So in general, there's very limited education around food and nutrition in medical school. But you must ask the question, are you not talking about this with patients and families? Patients and families are asking about this. Well, what do we end up telling patients and families? Well, what we learned from grandmother, what we learned from mother, what we learned from whatever magazine we were reading, oftentimes can be very off-putting, not recognizing the diversity of diets that are out there, not recognizing challenges around food insecurity, food access, and really treating food as not a deeply personal experience, but this absolute experience that is unique to the individual versus unique to our cultures and personalities. So I think there's a big challenge there. There's a lot we can do there. There's a lot we've been invested in around the country to really sort of improve this process, but there has been a big gap there for many, many years.
And I can remember even in my training, most of the training I got, I did have some nutrition training in the beginning, but in the hospital, it was a dietitian when we did the referral for certain chronic diseases that kind of told us the medicine, the science behind it, which was great. But definitely a point that I hope we can talk about a little bit more. But because this is a advocacy and policy panel, we want to make sure that we get to that as well. So I'm going to turn to Billy to ask a question specifically about what is the status of Representative Kelly's Food for Health Act and other legislative efforts focusing on food as medicine?
Yeah, thank you for the question, and it's really great to be with you all here this morning. And I guess I'll first start off with, if you're not familiar with Congresswoman Kelly, she does a lot of work in the healthcare space, has been a leader on maternal health, preventing gun violence, as well as some nutrition-related matters as well. And so we've always tried to view this as how can we sort of bring synergy between traditional healthcare and also nutrition. And I come at it from more of the agriculture and nutrition background with some of the items I cover for the Congresswoman's office. My colleague Michelle, you'll probably see her around here. She is more primarily focused on our traditional healthcare, our maternal health work, but we overlap on a lot of these things and try to work together. And so I guess I'll take it back to maybe about a year and a half, 2 years ago, we started hearing this concept, food as medicine, coming up quite frequently. The White House had done the conference on hunger and nutrition, and there was a lot of, like Kelly mentioned, there's sort of a movement growing in this space. And so we started hearing this a lot and said, how can we find ways to be involved in those conversations? And we really started with our district. Our district is urban, suburban, and rural. It always surprises folks that we actually have 4,500 farms in our district. So the Congresswoman and I spent a lot of time touring farms and hosting barn hall conversations, meeting with our agriculture groups. And some of those are traditional kind of commodity row crops, corn and soy, but we're seeing a lot of farmers doing innovative things with specialty crops and urban gardens and trying to be involved in strengthening local food supply chains and healthy foods at that. And so through meeting with a bunch of folks, we ultimately started hearing more about how these things all intersect and how do we utilize, emergency feeding organizations, how do we utilize healthcare centers, hospitals, federally qualified health clinics, and really try to add to the supply of fresh food via medically tailored meals or produce prescriptions. And so we worked to draft a bill and talked with a lot of folks on stage here. And we've used folks like Dr. Essel on a panel in the past to talk about these same issues. But our bill essentially would establish a pilot program with HHS and USDA to cover kind of a broad sort of wish list of items all related to food as medicine. And so produce prescriptions, medically tailored meals, nutrition education, even things like on-site pantries within hospitals. I think that is kind of a touch point where if someone with a diet-related disease comes in and they're screened and then we have the RDNs there to sort of oversee the process, how can we get them the food that would benefit them and either manage, treat, or prevent some of their conditions? I think that is a great point that you don't want to lose them at. And basically, we want to see more funding come to these types of programs. We're seeing it smaller scale going, across the country. There's pilots and there's programs. A lot of states are looking at 1115 waivers to try to get these programs up and running. There's other members of Congress who have more narrowed approaches on things like medically tailored meals with Medicare. I think as much energy and kind of ideas, the better. But our bill, specifically, we kind of view it as utilizing the community-based organizations, the emergency feeding organizations, with healthcare partners to try to really instill collaborative efforts to roll out these programs. And so we're really excited about it. We worked on it for a long time. We introduced sort of a placeholder last Congress. We're still working to reintroduce this Congress. We're trying to make it bipartisan, so we're talking with our friends on the other side of the aisle. They obviously are talking a lot about healthy foods and food dyes and various things like that. And so we're seeing if there can be any synergy. It's obviously, as I'm sure we'll get into, a tough environment for a lot of things, healthcare and nutrition right now. But yeah, so we're working to redo that. And then it's also the middle of appropriation season. So we're going to work with some of the leaders like Representative McGovern from Massachusetts and some others to try to see if we can make requests for additional funding with some of the existing programs and also try to expand food as medicine more broadly.
Fantastic. So there's lots of work being done. You have these programs that are popping up, but ultimately funding is what's going to be important. Because our conference is about data to action and want you all to leave here with action, our panelists have some data points they think will be important for you to know so it can help with the action that you take when you leave our panel. So I'm going to let whoever wants to go first with their data point, just don't want to put anyone on the spot, to give us a data point and what we can do about it.
Well, I can kick off just to kind of give a certain level of urgency of where we are right now. Billy just talked about Congress is in session. Congress plays a major role in a lot of things that we're dealing with. So some data points just to take away from you all. Again, I mentioned that SNAP program serves 41 million people. WIC program, which is we didn't get talked about, which is another federal nutrition program that's focused on mothers and young children up to the age of 5, serves about 6 million people. For children who are using school lunch programs, 70% of those children are either doing free or reduced lunch. That's just in perspective of the broad level of constituencies that are impacted by our federal nutrition programs. That said, there are policies that are under consideration right now, which will roll a lot of things back. And one key thing we have to remember is that we can't have nutrition security without food security. And you can't make America healthy again without those two are tied together. And so some of the things that we are worried about right now are provisions that will drastically reduce SNAP benefits for families. House right now, House of Representatives is going to consider a bill which may cut $230 billion out of Department of Agriculture. That can't be done without touching SNAP. There's an effort right now. There's thoughts right now that they may zero out fruits and veggie benefits in the WIC program. We already heard about cuts to school meals. These are all things that will impact the ability for low-income families to be able to have access to healthy, nutritious meals. On average, just to put some dollars and cents to this, and then I'll shut up. The average SNAP recipient receives about $6 a day in benefits. Now think about what you can buy for $6 a day. It's not much. And so these programs are used as a way to fill gaps for families who cannot afford healthier foods. But there's also, on top of that, with the certain incentive programs that we talked about, making these healthier foods more available to low-income families allows those families to make their dollars stretch. So these are just policies that we got to look at, and we have to have these conversations where we talk about big picture around the impact of these cuts and what that will mean. And as health providers, definitely I want you all to think about this from your perspective of making sure that your patients have access to healthy, nutritious foods at home.
I'll just add to that. Thank you so much for that. The data shows that people who receive SNAP, which by the way is not like their whole life, it's for a moment in time usually when they're experiencing economic stress. The data shows that they purchase the same foods as everyone else, maybe in different orders, and that's just a reflection of the money that they have available. So they're just like everyone else trying to put healthy food on their plates for themselves and their children. And that response to food insecurity is so important. And that referral from a doctor, just table stakes, when they're seeing somebody who's experiencing malnutrition or trouble getting enough food, referring them to SNAP, making sure the kids are in school lunch and receiving or on WIC, that's really important. Then the next step is making sure there's a clinical intervention if that's needed. And so I mentioned that medical nutrition therapy is reimbursed right now for diabetes, renal disease, and post-transplant. We have evidence that it works on so many other things, but it only got approved for that because of the money. So we need to really invest in prevention. And when we do invest in prevention, we actually see the cost of those patients who are getting treated for diabetes and renal disease and post-transplant, that their medical costs go down over the long term. So even though it might cost a lot to add medical nutrition therapy for cancer, obesity, and other things, we know that the costs are going to go down by doing that prevention overall long-term healthcare.
Absolutely. And I don't know how many other people in this room, I definitely was a WIC kid, I definitely was a SNAP kid for a little bit, and I am floored that this may go away because I know what it did for me and my family. So,
Same.
Yeah, I'm sure like other people, you may not say it out loud, but you remember what that was like, and that helped you get some healthy food in your house. So.
Yeah, I want to do some foundational pieces with this really quickly. I think it's important. So we are highlighting the role of food insecurity and how it impacts families across this country, right? You see that one in six households with children are experiencing food insecurity. 1 in 7 households across the board. We get it. Very, very important, very prevalent, very ubiquitous around the country. Every single county in this country is experiencing food insecurity, hands down. Food as medicine engages food insecurity. It also doesn't stop with only food insecurity. And it's important that we establish that and make sure we're aware of that as well. We are not watering down it at all, but we have to understand that this problem that we're talking about is expansive beyond food insecurity as well. How do we say that? How many adults in this country have hypertension? 1 in 2 adults. 60% of adults have at least one chronic condition. 40% have 2 or more. How many adults have prediabetes or diabetes? One would say, when I talk to my students, 1 in 5, 1 in 4, it's 1 in 2. 1 in 2 adults has prediabetes or diabetes. When we look at 1 in 2 adults versus 1 in 7 households, they don't always overlap. Not to say they don't contribute to each other, because households that experience food insecurity have much higher rates of diet-related chronic conditions as well. So we have to engage all of these at the same time, but we can't only stop to say, when we're thinking about and engaging this topic of food as medicine, we're not only thinking about food insecurity. I just want that to be clear here. Another foundational piece we need to understand is we're throwing out words like medically tailored meals and groceries. Just want to really focus on that for a second. Typically, when people talk about food as medicine, you'll see them highlighting a pyramid, a food as medicine pyramid. On the left side of the pyramid, you'll see at the base of the pyramid is focused on prevention. At the apex of the pyramid is focused on strategies using treatment. There are typically 6 different approaches that people talk about. Medically tailored meals, the most poignant, directed way using the most expensive tool that we have for addressing disease. Medically tailored meals are pre-prepared meals designed by a chef and dietitian, designed to give you 50% or more of your calories for the day. They're delivered to the home, they're ready to heat and eat. Right? You can store them in the refrigerator or the freezer, depending on their frozen or fresh or whatever, but you're just throwing in the microwave, you're ready to heat them and eat them, right? So think about a family who's had a recent surgery, having difficulty getting around the house, having difficulty getting to the kitchen or the grocery store. These meals can prevent rehospitalization, can prevent malnutrition, can give them the nutrients they need to optimize their health. They can also be used for a variety of other things as well. Medically tailored groceries, number 2. Medically tailored groceries are produce, fruits and vegetables, and other items as well. Whole grains, nuts, seeds, legumes, other items as well. They can be packaged, delivered to the home, or picked up at the grocery store, but these give a lot more autonomy, right? An individual wants cultural preferences, the foods that they enjoy eating, giving them the ability to go and purchase the grocery items they want. They can then adapt those foods to the foods that they want, the foods that they enjoy. It also can build more skills than medically tailored meals, right? Because you're having to prepare the foods. That's why whenever we talk about any of these interventions, we need to be working alongside high quality nutrition education as well. There needs to be a synergistic effect. This is not just providing food, this is not just providing education, it's how do we bring the synergistic worlds together, right? So that's number 2. Number 3, produce prescriptions. Produce prescriptions are fruits and vegetables. It can be fresh, frozen, or canned, right? Just providing fruits and vegetables, one may say, why is that valuable? We know that only 1 in 10 adults consumes enough fruits and vegetables. And children, I'm a pediatrician, only 1 in 10 children consume enough fruits and vegetables, right? So there's an issue, there's a huge gap here. Providing more fruits and vegetables improves the microbiome, right? It does so much more to our overall health. We've seen changes in A1Cs and blood pressure and overall health. I mean, the list goes on, simply by providing produce. The last 3 categories, number 4, nutrition security programs, federal nutrition programs rather, let's just say that. Federal nutrition programs, SNAP, WIC, school meals, everything Eric is highlighting. These programs are dynamic, they're effective, they're evidence-based, they work. We can lean on them, we recognize the effectiveness of them. Number 5, community and local policies as well. Community programs and local policies. Food as medicine should not eliminate local community infrastructure. Right? A lot of this work is phenomenal. It's going around the country. These are some new initiatives coming in, but the local community infrastructure has been what has got us to this point. Let's not eliminate that. So that's a really critical piece as well. Our food banks, our food pantries, our soup kitchens, and last but not least, number 6, high quality, empathetic, personalized nutrition counseling and education. How do we meet members where they are, people where they are, providing high quality education, recognizing that every healthy eating doesn't have to look like rice cakes for breakfast, lunch, and dinner, or that sad salad that people have in their minds. We can adapt it, right? Recognizing blue zones. People eat differently all around the world and have benefited from it. Why does it have to look only one way? So these areas are the 6 areas I want us to think about. To answer your question, the data point that I think is critically important is there's still questions we're asking around food as medicine, right? So for produce prescriptions, for example, how long should we be doing this? What's the right amount of produce to be providing? What do we do after the program ends? We just send them back into the jungle and say, figure it out on your own, right? When we don't have resources around, what do we do in these situations? So the data points are really getting a better sense of how effective we can be by sort of tweaking different elements of these programs. Once we can understand that piece better, it's gonna make this whole movement much more effective as well.
How many of you learned something from that conversation, right? And knowing that there's levels to it, and culture plays such a good part when it comes to grocery, like allowing people to make their own meals. And then also the age preference, like when you do the medically tailored meals, I find that my geriatric population loves that because they don't have to cook, they don't have to worry about it. It continues to allow them to do their ADLs without having to think. But then my moms with small kids, they're like, my kid's not gonna eat that. So knowing that there's levels to everything and keeping in mind the action that we need to take to make sure that these programs continue to exist and the policies that come with it. So Billy, I'll come to you.
Sure.
let's bring the
Yeah.
policy, the advocacy
Well,
into
it's
it.
tough to go after everyone else who spoke because they really hit, everything that we agree with as well. And especially talking about how these things sort of work in unison with one another. If you cut SNAP, if you cut WIC, you're likely going to see rising rates of food insecurity, rising rates of related diseases, as well as the medical nutrition therapy. I should note, outside of our Food for Health bill, which is more focused on food as medicine programs, we also have a medical nutrition therapy bill that we're working to reintroduce. And my colleague Michelle sort of takes lead on that. But exactly what Kelly mentioned, trying to expand what services are covered and what RDNs and folks like that can get paid. And so those are some things just that came to mind when the others were speaking. But the stat, as we talked about the concept of medically tailored meals, it came up that maybe they're the most cost intensive and the most sort of strategic and narrowed focus in terms of providing food to help treat or prevent or manage a diet-related disease. And Tufts University, who have been leaders on kind of the food as medicine and that space for a long time, they came out with a recent study, and I was looking through my notes this morning. Obviously, everyone is concerned about funding and costs and healthcare, as well as what's happening in Congress, right? That's a huge focus, particularly for the Republican Party right now, as they look to potentially cut $230 billion from the Agriculture Committee, which will touch SNAP, or $880 billion from the Energy and Commerce Committee, which my boss sits on, which will touch Medicaid. And so it's really tough to kind of grapple with making investments when we're in this current climate. But medically tailored meals the data is starting to show that they are a good investment to make. And so just in Illinois, I was looking, for eligible populations, they simulated Tufts University that they would save approximately $2.8 billion annually through the provision of medically tailored meals to treat diet-related disease, compared to just traditional healthcare. And then also comes out to something like, I think they said like $2,500 for each patient, right? And so these things, while they may cost money up front, we're saving money in the long run. And I know everyone knows the stat about diet-related disease, I think costs, $1.1 trillion annually to the US healthcare system. We know these things can help, and it's sort of making the investment before you need the ultimate hospital stay or serious medical interventions. And so I think we know these things work. They all work in unison. We really have to strengthen our basic nutrition assistance programs, as well as really try to build out food as medicine programs, medically tailored meals, produce prescriptions, and see that hierarchy to its fullest and its full effect, right? If we cut one part of it, we can't get to the top level. And so it's really important that we continue to invest in all our nutrition programs, and then hopefully get even more and more data on the kind of higher level medically tailored meals, produce prescription, things like that.
Amen. So we got some data. You know more about who these folks are and what they're doing. I'm going to ask them another prepared question that I have for them, but then we're going to open the mic. So that's a little bit early for what y'all used to. You're used to the last 5 minutes, but I did want this to be a dialogue so we can have a healthy conversation, especially about, this is a political policy and advocacy conversation. There's so much going on right now, so I want to make sure you all get the opportunity to take the mic. I am going to start with Billy, though, because we have all this information, but what do we do about it, right? So I want to ask you specifically, in what ways it says healthcare professionals, but healthcare professionals or anyone who's interested in this work, how we can engage at Capitol Hill to create momentum for these issues in Congress?
Yeah, well, I'll start off with, and maybe you guys have figured this out, Congress doesn't know everything. We're not experts on every given issue. And so it's really important that we hear, and the Congresswoman particularly, she always references that it's so important to hear from folks. We have an open door policy. We always want to hear from folks who are doing the work on the ground, right, who are in these professional settings. For example, for myself, so I'm a senior legislative assistant. I cover like 7 different issues for the Congresswoman. So I may meet with a group on nutrition, food as medicine related issues. The next group I'm meeting with veterans groups, or I'm meeting with defense or transportation or energy or environment. And so my time is very spaced out. I'm jumping from issue to issue. And it also is dictated heavily on what Congress is doing, right? If Congress is focused on the Farm Bill, if we ever are going to get to see some of the reauthorizations of these federal food assistance programs, we need to do a Farm Bill. If that's front and center that week, that's where my energy is going. If it's something else, that's where it's going. And so I really benefit, and my colleagues will attest to, from hearing from you all, especially when we're drafting legislation. we worked on that bill for a long time, and we're unable to make everyone happy and give everyone sort of the opportunity to say what they think would work best, but we're trying to get that feedback as we're shaping legislation, because I might say, hey, this sounds like a great idea. I think, if we orchestrated the bill this way and this group played a role, that would be great. And then they may say, it'll never work like that, because you folks are obviously in the settings dealing with patients. And so we really value hearing from you all, on food as medicine and also other issues. I think it's important also that, especially in this current climate when everything feels so intense and funding is threatened and the stakes are so high, on all sides, right, Republican and Democrats, we need to hear from you all, especially if you're in rural red districts, the importance of talking to your members and their staff about what would happen if the cuts that are being proposed were made to these programs. I think that is so important. So it's important on kind of the general sense, and then as we get more tailored, specific, into the weeds kind of policy ideas, I think it's really important to hear from you all. So we have a better sense of how can we help you and what's most effective.
Thank you for that. I'm going to go to Eric with this question, just so when we go in and we give the information that we're further educated about it. How does the food as medicine fit into what we understand so far about the MAHA initiative of the U.S. Department of Health and Human Services?
Well, when you say what we understand so far, the funny part is we're still trying to figure out what that really means. But on paper, you would say that food as medicine would fit within what they want to accomplish. However, the policies that we're seeing rolling out, I think, and personally contradicts everything that they're trying to do. For example, when you're looking at requests from numerous states to restrict SNAP benefits, or at least restrict what people can purchase using their SNAP benefits, it doesn't take into account whether those individuals have access to healthier foods, whether they live in a food desert or what have you, whether they can afford healthier food options, and how are they able to get to those stores and places where there's healthier foods. Rather than telling folks what they can and can't buy, we should be looking at, from my perspective, MAHA means looking at our federal nutrition programs, which addresses the most vulnerable populations of our country, and how do we ensure that those programs are actually providing access to people, and what can we do to improve access, availability, and affordability for those individuals. So some of the pilots and incentives that I talked about, like double your SNAP bucks, maybe investing more in that to where it can expand even further. The GusNet program, those are all different things that, again, are already put in place to make healthier foods more affordable for individuals. Let's see what we can do to improve those incentives. Finding ways to incentivize bringing grocery stores into local communities that do not have access to healthy foods. I used to live in Southeast DC. We finally got a giant grocery store in that part of the city a few years ago, and even still, the products that's there, you will go somewhere else in a more affluent part of DC. They don't have the same amount of options that you see there. Kind of to piggyback on what Billy was saying. So I'm two parts. And one thing on my resume, I'm a former Hill staffer, and he is absolutely right. We know enough to be dangerous, but we're not experts in these issues. And oftentimes, my old boss used to say, the squeaky wheel gets the oil, and what I encourage you all to be are the squeaky wheels. Yeah. All of y'all are health professionals you understand you understand what these actually mean to your patients and to the individual lives of people. Bringing that lens and that conversation to this larger conversation around food access, food security, nutrition security is key. And so I would encourage you all to also look at these policies from that lens. And as we're talking about these larger issues around healthcare, health access, making healthcare more affordable, you have to also think about what does food security play in that conversation.
Mm-hmm. And to back up for a second, what does MAHA stand for?
Oh, Make America Healthy Again.
Just so we're all on the same page. So educators, make sure we're all on the same page. I know Congress folks and representatives like to hear narratives. Narratives, as they say, put it in a narrative, it usually sticks and it helps. So Kofi, tell us more about how can you describe hunger and how it impacts your patients and families in a clinical setting, and how we can bring that in?
Oh, great question. Typically, when I talk to patients and families and think about sort of the journey of hunger for my families, For the last 10 plus years, I've been a provider in Anacostia down the street in DC, seeing a variety of families that I love, and I really have enjoyed my role as a community pediatrician. Some of the things that they've shared with me is that one of the triggers to hunger is not just not having food, typically is some sort of sudden impact to one's income, right? When a sudden impact to one's income occurs, it sets off a cascade of coping mechanisms that family has to put in place to maintain a sense of stability. One of the first things to drop in one's home when you have an impact to your income is your food budget. Because the food budget is so flexible, so fungible. So many of us have been in situations where we've had to change what we've been eating, maybe, for example, in schools and different things like that. For me, like even thinking about like college, and I had to change what I was doing because I didn't have the resources. So what do I do in these situations, right? So that food budget is so flexible, so fungible. So the first thing families typically do is change or drop their food budget. But at the end of the day, what we also realize is that food insecurity doesn't travel by itself. Hunger travels along with other social drivers of health as well. So the cascade of coping mechanisms, number one, family says they have this sense of food anxiety, a constant preoccupation, constant perseveration over where one's next meal is going to come from, right? So they're worried, they're stressed. Where am I going to get that next meal from, right? The next thing after that food anxiety is the quality of food will begin to drop. We call that a monotony of the diet. The diet becomes very simplistic. You're getting the same foods over and over and over again. Why? Because when I meal plan, like this person told me to do, that uses a lot of cognitive bandwidth. But with the stress being already high, my cognitive bandwidth is low. My ability to shift and focus on many things is very hindered. Let me get the same foods over and over again because it takes less stress on my brain. Let me get foods that I know my children and my other vulnerable members in the home are going to eat, because if they don't eat it, that's going to increase waste and that's going to increase stress. Fruits and vegetables? You tell me they're going to last how long? Let's not get any fruits and vegetables. Let's get things that I know are going to last. Again, typically are going to be more ultra processed, going to be cheaper, easier, very convenient, hyper palatable, incredibly flavorful. I'm going to lean towards those foods. The last step is after the quality of food will begin to drop, the quantity of food will begin to drop. Well, whose food drops first? Adults, because adults love their children. So adults will try to create sort of a barrier for their children so they don't see it. So adults will drop their food intake first, and then lastly, children will drop their food intake. You may say, okay, well, children are protected. We're not really worried that much. You must not see that much in clinic. The reality is, when that temperature increases at the first stage of that journey, everybody in that home feels that increased stress, increased temperature, in a variety of other ways as well. Just because food is not dropping, the intake is not dropping, that stress increases. And when toxic stress increases, it creates permanent changes in the brain. It creates increased sort of poor outcomes and worsening health. And that's what we worry about across the board. So that's what typically families share with me.
I'm just giggling to myself. I'm thinking about my 6-year-old who will only eat broccoli. That's the only vegetable she'll eat. But you're thinking about it, it's like it's stress. It's less stress. You do the same thing. You want them eating. There's no stress when it comes to buying food. So it goes across the income field too. So it's not just those who are stressed, but also those without income. But every adult in here is thinking about what I'm going to eat for dinner and how it's going to come across. Kelly, we're talking about food as medicine in general. What, from your perspective, what is the impact that we want to have in this movement? What are we aiming to achieve?
Sure. I first just want to acknowledge, Kofi, you're such an amazing storyteller, and I've heard you many, many times, but you literally just walked me down my childhood experience with hunger and food insecurity. And maybe that's happening for other people as well. And it really does impact your life, and it's actually probably why I'm in the field of nutrition. And I feel so passionate about this. So number one is to make sure people can really activate and have a happy, healthy life and actualize on what they're here for, rather than freaking out and having that anxiety, which is real. That's what food as medicine is about. How can we help our clients or people live their best lives and show up for the birthday parties they want to be at, show up for work and be able to produce and be productive. And given the audience, I would say, and what Kofi talked about earlier, you don't need to know everything about nutrition, but know that you have people out there who can help you, help your clients, help your patients, and be part of your interdisciplinary team. And I love it when doctors are involved and engaged in nutrition. It's really important and become this collaborative team because we actually end up not missing things. And depending on how we approach with empathy to a client, we can kind of learn like what's their motivation, what would help them do better, and rather than me and what I think they should do. So having a solution that supports the dietitian, supports you as the medical provider, and supports the patient. And really making sure that we're looking at community-based solutions. What works in Colorado may not work in Portland, Oregon, may not work in New York. So really tapping the knowledge and the expertise of those community-based organization advocates and experts who've been working on this for quite a long time.
Amen. So we had some education, you know who these folks are. We gave you some data. We talked about something you can do. Now I'm going to open the mic for folks to ask questions. So I know this group well. You can get to the mic, introduce yourself, but no soliloquies. I'm from the Deep South. I will politely cut you off, but just you can introduce yourself and please ask a question. Don't be afraid to come to the mic and ask a question. I think we have someone at the mic now. We have this mic and we have this one as well, but I'll call this mic 1 and this mic 2 just in case folks start to jump up. So please.
Hi everyone, Audrey Davis, Cancer Support Community. I'm in Oncology Patient Advocacy. You all talked about food being cultural, but I think food is also comfort, right? I'm thinking about my dad when he was diagnosed with stage 4 colorectal cancer, being originally from Haiti, wanting to go to the local Haitian restaurant, and maybe it wasn't the healthiest option. I saw how much grease there was, it wasn't, but for him it was comfort. Thinking about my mother-in-law going to Chinatown. My question for you all is this: what partnerships are you all working on with not only community-based organizations, but also local restaurants, grocery stores, et cetera, that keep in mind the ethnic, cultural comfort component of food as medicine?
That's a wonderful question.
Maybe I'll just kick off with dietitians. That is part of our training. And we have thousands of dietitians across the country who are looking into and providing education around the neighborhoods that they are in and the people that they are working with, which are very diverse. And that's, you know, the first thing we're talking about is what's good for me is not good for you necessarily or desired. And so helping people, but like Kofi, or maybe you mentioned, there's not always access. I think you mentioned sometimes it's not a grocery store, and you mentioned the Giant, and I lived in that neighborhood too when it came on board. And before that, it was just a smaller store. So if you didn't have a car, you couldn't get to somewhere, you couldn't get to the farmer's market. And the other thing I wanted to mention is that Giant, and I go there every once in a while, it's still cheaper in my neighborhood in Northwest than the Giant in that neighborhood in Southeast, and that's wrong. And so we need to also fix that and make it more accessible for people to buy the foods that they want to have on their table.
Good question. Go to mic 2.
Good morning, everyone. My name is Raven Parker. I am one of the grant managers at NMQF. Thank you all for coming. So I have a few questions, but I'm just going to limit it to one out of respect of everyone in time. And it's kind of hard for me to choose, but so maybe the systematic approach to access and conservation of community gardens, sanctions, and also the responsiveness or holding the local government accountable is the topic in general. The question is, how can we hold the local governments more accountable since, you know, with our new administration, it's ever changing and in many ways ever challenging. So when I was growing up inner city of Waterbury, Connecticut, I was raised to use my voice. How I'm thinking of it to, you know, finish up my question is, growing up, I used to think of the federal government as kind of like an older sibling that maybe we could go to make sure the local governments were held accountable. But because our federal government is changing, how can we hold the local governments accountable? Thank you.
Yeah, I guess I can jump in, and if you're a DC resident, obviously, DC is in sort of a tricky place given just the funding stream and how that all works. I think you have to use your voice, right? I can speak, you know, only for kind of my boss and what we're doing, but we're doing things like back in Illinois, we're doing town halls, We're doing visits. We went to a food pantry in our district to talk about potential SNAP cuts. We are trying to meet people where they're at. And one of the number one questions at every telephone town hall or in-person town hall my boss has done recently is, what can I do? How can I get involved? And I think we're at a sort of unique time, right, where we're seeing a lot of this play out in the courts, and so we're going to have to hopefully rely on the judicial system, because unfortunately our legislative branch has kind of seceded its power in some ways, and they're afraid to challenge the executive, and so I think that's just making the entire government a very tricky place to work in right now. But I think we have to continue to just raise our voices, show up, call people out, call your elected officials. But then I think you bring up a good point too of when the federal government isn't fulfilling its duties and not meeting the needs of its constituents, that's sometimes where state and local governments can have kind of a preventative impact. And so, if DC or your state or, your city can leverage funds or move money around so that they can help sort of fill in where the federal government is falling short, I think that's super important at this time. But yeah, it's a really tricky spot with the federal government right now in the current landscape.
LaTasha, can I answer that as well? Just so I was at a visual yesterday, and I want to even say it was Congresswoman Kelly who said this, that obviously advocacy plays a huge role. It's not just on the federal level, but that advocacy, making your voices heard at the state and local level, is also key. And to the point now where everything is hyper politicized, it is important for your state reps and your governors to hear your concerns, because they are the ones who have access at the federal level. To the point that I was just reading an article today where I'm talking about, I just mentioned around the threats we're seeing around SNAP. There's efforts to kind of push some of the federal burden down to the states, but some of the quote unquote red states, or the states that they feel voted for Trump, are pushing back and saying that, and there's concern now that these states can't afford to cover those gaps. And so now that's starting to resonate and bubble up to USDA, which is starting to bubble up to the congressional members who have to write these proposals around how these cuts are going to be disseminated. They're starting to hear these concerns. You're hearing it around Medicaid as well. All of a sudden, there's an effort to want to quote unquote protect Medicaid when they know they still have to cut $800-something billion out of the bill that funds Medicaid. But they're telling you they want to protect Medicaid. It's because they're hearing from state and local, as well as people back at home, that you can't touch our Medicaid. So that pressure point has to not only be at the federal level, but also at the state and local level.
And go to your state and local meetings. There are local neighborhood meetings that happen all the time. Who knows who their alderman is, right? Who knows who their supervisor is for their neighborhood? So knowing who the local officials are, so you can, because I've been in those meetings and there's very few people at those meetings, unless you're in DC Ward 7A, we show up at those. But making sure that we show up at those and run for those. I can name some names, I'm not gonna do it. People in this room that could probably run for state representative right now, but you don't look at yourself that way. So I'm gonna throw an action out there. Look into the requirements to become a state representative for where you live. Look into the requirements it takes to be a local representative for where you live, because believe it or not, it doesn't take a lot of hours, and you all are extremely equipped to run and be in those positions. So I would definitely encourage you to consider it. So I think Mike 2 was up before Mike 1, or or was he up first? Okay, Mike 1.
Oh, you're sweet. Thank you. Hi. So thank you all for being here. I think this is an amazing topic. I'm a family medicine physician by trade, and I have been in correctional medicine for quite some time. And I believe this conversation of food is or as medicine is not a new concept for us. I think culturally we have been doing it for quite some time in multiple different ways. And I often think about the correctional setting because you have a captured environment, literally. And they have been required by the 8th Amendment to have medical care, which means you have to do tailored medical prescriptions for their care. And we have seen decrease in their chronic diseases, decrease in hospitalizations. So systematically, we've proven the improved health outcomes and decreased costs. So my question then becomes, what have you found as being successful, and then what are your barriers when it comes to implementing these policies, and what are you coming up against? Because I can tell you, think about the inmate, because they will sue when they're not getting the proper diet. they have different things that they are using. And so sometimes I think if we think outside of the box, like some of our creative inmates, we might be able to get around some of the barriers we have in Congress and other areas in federal government. Thank you.
I can't speak to the policy part, but I can tell you about programmatically what has been working from our end. So something I haven't mentioned much. So I work at Elevance Health. Elevance Health previously was known as Anthem. It's the second largest payer in the country, over 47 million members around the country. And my role is the Food as Medicine Director there. So I create interventions and programs using food as medicine as a tool to improve health outcomes around diet-related chronic conditions, food insecurity, nutrition insecurity, the list goes on. But one of the things that we've seen is that there's a ton of engagement and excitement around this topic. But if you look at the data points around the country, a lot of these interventions have been quite small. 200 people here, 300 people here. I always make a big argument. There's not much in the pediatric space. A lot of the emphasis has been in adults because adults carry the burden of disease and all these things. And so we're advocating for more of those kind of studies and across the board. We see the effectiveness of medically tailored meals. Right, those programs have been done for many, many years. We've seen them time in and time out. We're seeing Medicare really lean into those programs, right? Produce prescriptions and medically tailored groceries, we're starting to see more of a swelling of those kind of programs, more advocacy around those programs, trying to figure out how to really make them more effective. We see them in the literature outside, but what does it look like in the practical world, working with members in different settings, in commercial, in Medicaid and Medicare? Those are the difficult parts here. But across the board, we are implementing these programs. We're seeing food be used as a great tool to engage members, food be used as a great tool to actually improve health outcomes. And there's also quality improvement that's occurring. And yeah, at the end of the day, what's happening with cost savings? One of the biggest investments into food as medicine from this lens is we're seeing the cost of healthcare go up significantly. So can this be used as a tool to help to curb the cost of healthcare, also recognizing members, patients, families are asking for this as a tool to improve their health as well. I get it, I want to tap into medications, I'm using my medications appropriately, doc, but can I also tap into these foods as well? I keep hearing about this, can I use that? How do we work alongside patients and families to help them improve those health outcomes? So those are some of the things that we've seen to be quite successful there.
Yeah, I would just follow up briefly if I could. Thank you for bringing it up in terms of kind of the criminal justice system. That is something I was not looking at, but I think that'd be a great idea to sort of look how we can study. And I think we're seeing this in like IHS and within the VA system, right? Any sort of institutionalized setting, I think it's easier to implement some of these things, and it's also easier to track the data. And so I think that's how we're going to continue to scale and see more and more data showing the effectiveness, showing the cost reductions. And that can help us sort of broaden these programs.
In the essence of time, we only have time for one more question, and Mike 1 was standing first, so I'm going to have you answer, and then we'll have to wrap up, unfortunately. But our panelists will be here if you want to ask anybody anything individually. Yes.
Thank you all. Zachary Hermes, cardiologist, population health management at Master Brigham. Kofi, I'm going to direct this at you. I think much of the conversation was rightly focused on federal programs, Medicaid, SNAP, WIC. Kofi, I'd love to hear from you from a commercial perspective and also thinking about MA even concretely, practically, how are payers looking to push the envelope and again begin to scale and really rigorously pilot these programs. As we know, as I think was called out, food as medicine is also a nuance and separate from nutrition security. So we know there's a big, I focus on cardiovascular kidney metabolic syndrome, and I think of food as medicine as really a structural component of care for that patient population, regardless of actually financial status. So I'd love to hear your thoughts about practically what are payers doing to begin to scale and push the envelope.
Love it, love it. Let me start with this piece here. Kelly, I always say this, and I haven't said it yet today. I started off talking earlier today about this concept of training doctors to do better and engage nutrition better. The goal of that concept is not to make MDs RDs. right? We cannot replace the work that RDs do. RDs are phenomenal in what they do. We need to work alongside each other better. One of the things we need to do is do no harm. A lot of what we have done is more harm than good because of the lack of training in this space. Because of the lack of training, because of the inaccuracy in how we're communicating about this, the stigma we bring in this world, even around weight and the things goes on and on and on. There are better ways we can do this. When we think about the payer world and how we're engaging it, I'll highlight some of the work that we're doing in this space to really think about this in a nuanced way. Number one, we work in commercial, Medicaid, and Medicare. And oftentimes when people talk about food as medicine, they're only thinking about, well, isn't this really just a program in Medicaid or in Medicare? No, 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 no. Again, across the board, diet-related chronic conditions are prevalent. Poor nutrition is the leading risk factor for premature mortality. It's the leading risk factor for premature mortality. So this can be used as a tool across the board. So at the end of the day, a few things that we're doing. Number one, we're trying to make sure that food as medicine is a core component to every single line of business, okay? To how we're building out our programs. We're building out novel interventions and programs and standing up through all lines of business. Even if you talk about food insecurity, right? People are like, oh, food insecurity in commercial? That doesn't exist. Come on. At the end of the day, it's ubiquitous. It's everywhere. Let's not just think about this and narrow in and allow our biases to determine where food insecurity exists. So we're engaging it in all lines of business. Number two, we're trying to advance a digital-first approach to food access and education. Are there digital tools that we can use to improve access to food and education, recognizing that there's difficulty accessing food in different parts of the city, in the region, in the county, in the city? How can we do that better? And then number three, how can we lean into advocacy? Advocacy around thought leadership, our communication, how we talk about this, providing a source of truth that people can rely on, right? How can we do this around education, improving education and medical training, improving education and how we engage this topic, public advocacy, and research as well. We're trying to put a lot of research in this as well. So at the end of the day, we're building out programs across the board in every line of business that does this, that uses medically tailored meals, groceries, produce prescriptions, working alongside doctors, nurses, patient care technicians, teams, and nutrition education to implement these programs so docs aren't having to do everything on their own, right? The dietitians aren't all having to do everything on their own. We're trying to bring the worlds together.
Thank you for that. So that's it, y'all. We got 38 seconds. Not time to ask another question. Not time to do any final thoughts. So we want to give our panelists a round of applause. They'll be sticking around. It's lunchtime, so food is medicine around lunch. Make sure you eat your vegetables. So thank you all for coming. All right.
Thank you.
Thank you so much.